Hello, myself Dr. Harshal Ekatpure. I am consultant endocrinologist and diabetologist at Ruby Hall Clinic, Pune. Today I am going to discuss an interesting case about poorly controlled diabetes with the risk of hypoglycemia. So here is a 50-year-old gentleman with type 2 diabetes since last 2 years. Came with frequent hypoglycemic episodes in past 2 months. He was on metformin 1000 mg twice a day, that is full dose, sulfonylurea 2 mg twice a day, that is again full dose of sulfonylurea. That is very poorly controlled, HbA1c of 8.2, LDL cholesterol of 90, triglycerides 126, creatine of 1.1 with EGFR averaging around 90. And on examination, he is obese with BMI of 30, BP maintained around 120/70. Now, is this patient, we need to actually address the hypoglycemia events first because the reactionary or hypoglycemia leads to the episodes of binge eating and leads to the further weight gain. At the same time, in long term, it can lead to increased cardiovascular mortality and morbidity also. So, to reduce the risk of hypoglycemia, we need to look at the options which are more glycemic or cardiac friendly, or the options which gives us the cardio-renal protection. So primary treatment consideration will be to reduce the hypoglycemic episodes, bring the HbA1c level below 7%. So achievement of HbA1c below 6.5 is also acceptable, but provided that we should be doing it without any excess risk of hypoglycemia. So in type 2 diabetes, epidemic has reached very peak globally in recent years. In last few years, we have seen the sequential or progressive rise in the incidence of type 2 diabetes. And as Indians, we have more earlier onset of diabetes. We carry more body fat for our given body weight. Our body makeup is such a way because of our genes that we carry more fat and less of a muscle mass. So there is an accelerated risk of developing diabetes and diabetes related complications in Indian subset of population owing to the early onset of diabetes. So strict glycemic control, it's very critically important in people with type 2 diabetes because that can lead to the further complications. Sulfonylureas are useful medications for control of blood glucose level, but they are strong medication, has to be used very judiciously and very appropriate doses because hypoglycemia is the major concern associated with sulfonylurea and subsequent weight gain. So rationale for combining the DPP4 and SGLT2 inhibitors, which are relatively newer anti-diabetic agents, and they act by insulin-independent mechanisms. So the CV protective effect of SGLT2 in patients with type 2 diabetes, and at the same time CV neutral effect of DPP4 inhibitors is the ideal combination for treatment of type 2 diabetes. And when we look at the HbA1c reduction individually, SGLT2 inhibitor 1%, around 1% we can expect, and 0.5 to 0.6% HbA1c reduction with DPP4. So with combination of these, we can expect around 1.5% HbA1c reduction and weight loss effect, that is a additional 2 to 3 kg weight loss effect can be observed. So it is recommended by all standard bodies that when you want HbA1c reduction of 1.5 to 2%, and at the same time patient is obese, you want additional benefit of weight loss, and you want to give a CV protective benefit to your patient because our prototype patient is around 50-year-old, middle-aged, uncontrolled diabetic obese. So many risk factors are already there for development of cardiovascular disease. And his HbA1c is 8.2. So we are looking at 1.2% additional HbA1c reduction. So ideally in this patient, first we need to address the hypoglycemia, reduce the dose of sulfonylurea, optimize the dose of sulfonylurea, and then add on the ideal combination of SGLT2 inhibitor and DPP4 inhibitor, and ask the patient to monitor blood glucose levels very frequently at home, at least twice a week or once a week. And till the time the dose is settled or HbA1c comes under control, keep the patient on frequent follow. And we repeat his HbA1c after 3 months' time. We see a good improvement in his weight. The patient has lost around 1.2 to 1.4 kg of weight. HbA1c has come down to 7.3% in 3 months' time, so it is expected to fall further. So there were no additional adverse events associated with this combination. Surprisingly, the incidence of genital tract infection or genital fungal infection, which was seen with SGLT2 inhibitors, is far less when you use it in a combination with SGLT2 and DPP4 inhibitors. So in this class of patients, particularly obese, type 2 diabetes, uncontrolled, and high CV risk, SGLT2 DPP4 inhibitor is an ideal combination, and even before sulfonylureas, or sometimes in some cases even before metformin, also you can think of this combination to give a benefit to your patient in terms of better glycemic control, weight loss, and long-term cardiac and renal protection. So thank you all.